So I have a lot of information shoved into this presentation about understanding dementia. So I will try to pace myself, but if I realize we're getting short on time, I'll just kind of speed up a little bit. But if anyone has any questions, I should say, go ahead and put them in the chat box and we will answer them as we see them come in. And
Oh, Megan, I think we just lost your audio.
Unmute. There we go. Can you hear me?
Yes.
I don't know what happened.
Life.
Yes.
Thank you.
All right. So we're going to go ahead and dive into this. As you now know, my name is Megan Byers, and I am going to present, trying to get everyone to understand a little bit about what dementia is. So we briefly went over the objectives. So first, my goals for you are to define and understand the difference between dementia and Alzheimer's disease, recognize the different types of dementia, identify the signs and symptoms of dementia, learn treatment strategies, and to recognize the prevalence of dementia around the world, in the United States, as well as in South Carolina. So dementia is not a specific disease. It is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. Dementia is a brain disease and is not a normal part of aging, whereas Alzheimer's disease is a type of dementia. It's a degenerative brain disease that is caused by complex brain changes following cell damage. So Alzheimer's affects memory, thinking, and behavior. We will learn a little bit more about Alzheimer's disease here in a moment when we discuss the different types of dementia. So before we go ahead and try to understand the differences between the Alzheimer's brain and a healthy brain, we need to quickly highlight an understanding of what a healthy brain function looks like. So the brain, as we know, is a massive muscle. It is always working, even when we're sleeping. Our brain allows us to function. If something goes wrong with it, it reflects in our behaviors and thought process. So the cerebellum is the largest part of the human brain. It fills most of the skull. It is associated with higher brain functions such as thought. Oh my goodness, I'm nervous and I'm just messing up the words. The cerebellum is divided into 4 sections called lobes: the frontal, parietal, occipital, and temporal. So the frontal lobe lies just beneath our forehead and is associated with our ability to reason, plan, problem solve, and regulate emotions. Our parietal lobe is located in the upper rear of our brain, and it controls complex behaviors such as sensory integration of information of our vision and touch, so temperature, pressure, and pain, and also body and spatial orientation, such as your body positioning and movement, and your left and right differentiation. So the occipital lobe is located in the rear of our brain and is the major visual processing center of our brain. It receives information from the eyes and relays it to secondary visual processing areas, which interpret spatial analysis, so the distance, depth, and location. Then we have the final lobe, which is the temporal lobe, which is located near our ears. It is associated with processing our perception and recognition of auditorial stimuli, comprehending spoken language, verbal memory, visual memory, and language production. The hippocampus is a region of the brain that handles our memory, learning, emotions are also processed there. So that can be impacted when you have issues with the temporal lobe as well. And 2 more parts I want to highlight. One is the brainstem. It connects the brain to the spinal cord and controls our automatic features such as breathing, digestion, heart rate, and blood pressure. So the brainstem, I always say, it's our automatic processing. If you don't have to think about doing it, most likely the brainstem is controlling it. And then here we have what is also known as the little brain, and it sits under our entire brain, all of the loans, and associated with regulation and coordination of movement and fine muscles. So this is just another view of the brain, so you can see where different sections lie. So we have the cerebellum, the cerebellum, and the brainstem. And these two images here, I have them to say the difference between Alzheimer's disease and the brain. So keep in mind the functions of a healthy brain, we now switch to how the brain is impacted with Alzheimer's disease. Alzheimer's disease is the most common type of dementia, accounting for 60 to 80% of all cases. Because of its prevalence, research is centered around Alzheimer's more than any other types of dementia, which we'll address shortly. Even though research continues, scientists are not absolutely sure what causes cell death and tissue loss in Alzheimer's disease. However, they do suspect two types of protein, which are plaques and tangles. The top image depicts the path that plaques and tangles in the brain. These proteins tend to spread through the cortex in a particular pattern with Alzheimer's disease. However, the rate of progression varies greatly. Plaques are deposits of protein called beta amyloid that build up in the spaces between nerve cells. Tangles are twisted fibers of another protein called tau that build up inside of the cell. Though autopsy studies show that most people develop some plaques and tangles as they age, those with Alzheimer's tend to develop far more in a predictable pattern, beginning in the areas important for memory before spreading to other regions. Scientists believe plaques and tangles somehow play a critical role in blocking communication among nerve cells and disrupting the process that cells need to survive. It's the destruction and death of nerve cells that cause memory failure, personality changes, problems carrying out daily activities, and other symptoms related to Alzheimer's disease. The bottom image on the slide is an overlay of the progression of Alzheimer's disease compared to that of a healthy brain. So now we're going to move into the various types of dementia, and the ones highlighted we will address individually. So the first is Alzheimer's disease. So we know Alzheimer's disease is the most common type of dementia, and as a reminder, 60% to 80% of all cases. Of this percentage, approximately 200,000 individuals are diagnosed with early onset Alzheimer's. Many individuals living with early onset Alzheimer's are in their 40s and 50s, but it does include anyone under the age of 65. Alzheimer's is a progressive disease where dementia symptoms, remember those are memory, thinking, behavior, gradually worsen over a number of years. Specifically, Alzheimer's disease is a degenerative brain disease that is caused by complex brain changes following cell death. So vascular dementia is a decline in thinking skills caused by conditions that block or reduce blood flow to various regions of the brain, depriving the brain of oxygen and nutrients. The inadequate blood flow can cause damage and eventually kill brain cells. It is the second most common type of dementia, encompassing 5 to 10% of cases. Lewy body dementia is the third most common type of dementia, again accounting for 5 to 10% of cases. It is a progressive dementia that leads to a decline in thinking, reasoning, and independent function because of abnormal microscopic deposits that the brain cells have over time. Lewy bodies are also found in other brain disorders, including Alzheimer's disease and Parkinson's disease dementia. People with Parkinson's eventually develop problems in thinking and reasoning, and many people with Lewy body dementia experience movement symptoms such as a hunched posture, rigid muscles, a stiff walk, and trouble initiating movement. The overlapping symptoms suggest that Lewy body dementia, Parkinson's disease, and Parkinson's disease dementia may be linked in the same underlying abnormalities in how the brain processes a protein, alpha-cycline. Frontotemporal dementia is approximately 60,000 individuals between ages 45 to 65 have this type of dementia. It makes frontotemporal dementia the most common type of dementia for individuals in this age range. Again, that's 45 to 65, and that encompasses roughly 60% of the people with frontotemporal dementia. This type of dementia is also formerly known as Pick's disease and refers to a group of disorders caused by progressive nerve cell loss in the frontal or temporal lobes. The nerve cell damage leads to a loss of brain function, which rarely causes disorientation in behavior, personality, and or difficulty with producing or comprehending language. So Parkinson's disease or dementia is a decline in thinking and reasoning that develops in many people living with Parkinson's for at least a year after diagnosis. Parkinson's disease is a fairly common neurological disorder in older adults, estimated to affect nearly 2% of those over the age of 65. Recent studies following people with Parkinson's over the entire course of the illness estimate 50 to 80% of those with the disease may experience dementia. And the last type of dementia that we're going to talk about today is mixed dementia. It is a condition in which brain changes have more than one cause of dementia occurring simultaneously. Some physicians refer to this as dementia multifactorial. Researchers do not know how many older adults have mixed dementia. However, brain autopsies indicate dementia may significantly be more common than previously realized. So, for example, mixed dementia could be a combination of Alzheimer's disease, but also vascular dementia. And so physicians can't determine which one is the primary diagnosis. They may diagnose you with mixed dementia because you have characteristics of both. So warning signs of dementia: memory loss that disrupts daily life may be a symptom of dementia. There are 10 early warning signs and symptoms to be aware of. If you or someone you know notice any of these symptoms, please schedule an appointment with your doctor. Before going to the doctor's office, check out the Alzheimer's Association's doctor's appointment checklist to help you prepare for the visit, and it is available on their website as a very useful tool just to review and be prepared for. So the 10 warning signs include memory loss that disrupts your daily life, and it's not going into a room and forgetting what you were doing. If that was, my goodness, I'd be losing my mind right now. The second one is to challenges in planning and problem solving, difficulty completing familiar tasks, confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words and speaking or writing, misplacing things and losing the ability to retrace steps, decreased or poor judgment, withdrawal from work or school activities, and changes in mood and personality. So here are side-by-side examples for you. So signs of dementia versus typical age-related changes. So you have poor judgment and decision-making is a sign of dementia, whereas making a bad decision every once in a while is common in normal aging. Inability to manage a budget versus missing a monthly payment. Losing track of the date or season is also a sign of dementia, whereas normal or typical age-related changes include forgetting which day it is and remembering it later. Dementia is having difficulty having a conversation, whereas normal aging is sometimes forgetting which word to use. Another sign of dementia is misplacing things and not being able to retrace your steps. And then typical age-related changing is losing things from time to time. So risk factors for Alzheimer's disease. I mentioned briefly that most of the research is with Alzheimer's disease, so that's why I specified the difference between Alzheimer's disease and dementia in the slides. Because again, Alzheimer's disease is 60% of all cases of dementia, so most research is centered around that. So researchers believe there's no single cause of Alzheimer's disease. It is likely that the disease develops from multiple factors. Scientists have identified factors that increase a person's risk for developing the disease, and those include age, family history, genetics, and a few other things. Excuse me. So I will start with age. So age is the greatest known risk for Alzheimer's disease. And you may be questioning yourself, well, didn't you just say that age and dementia is not a common, well, aging and dementia are not common? Let me get that out again. That dementia is not a normal part of aging. It is not. However, even though dementia is not a normal part of aging, the older a person gets, the more likely they are to develop the disease. Research indicates most individuals with Alzheimer's disease are 65 and older. After the age of 65, the risk doubles every 5 years. And after age 85, the risk reaches nearly 1/3. So the older you get, the higher the chance you have for developing Alzheimer's disease. So family history is another risk factor. Those who have a parent or sibling with Alzheimer's disease are more likely to develop the disease. The risk increase if more than one family member has the disease. When the disease runs in families, other hereditary, environmental factors, or both may play a role. So with that, it's saying if you have a brother and a sister and your mother all have Alzheimer's disease, your risk for developing the disease increases as well. So your genetics, there are 2 categories of genes that influence whether a person develops a disease. That's risk gene and deterministic genes. Researchers have identified hereditary Alzheimer's disease in both categories. Risk genes increase the likelihood of developing disease, but do not guarantee it'll happen. The gene with the strongest impact is the APOE-E4. Researchers estimate that between 40 and 65% of people diagnosed with Alzheimer's have a risk gene. The other gene is deterministic gene, which directly causes a disease, guaranteeing that anyone who inherits one will develop a disorder. It is estimated that less than 1% of Alzheimer's disease cases are caused by deterministic genes. The other risk factors worth noting is that there's a link between head injuries, such as a traumatic brain injury, and a future risk for dementia. So the more you injure your head, the more likely you are to damage the lobes and develop any type of dementia. A heart-head connection, some of the strongest evidence links brain health to heart health. This connection makes sense because the brain is nourished by one of the body's richest networks of blood vessels, and the heart is responsible for pumping blood through these vessels to the brain. The final other risk factor worth noting is an overall healthy aging approach to life decreases the risk of dementia. Healthy aging can be done by adopting a healthy diet, remaining physically, mentally, and socially active, and avoiding hazardous intake such as tobacco products and excessive alcohol consumption. So that is just pretty much saying if you remain active, again, physically, mentally, and socially, you're decreasing your risk for obtaining the disease because you are constantly learning and having your brain engage in an activity. So that is important. So a diagnosis of dementia. There's no single diagnostic test that can determine if a person has dementia. Health professionals are almost always able to determine if a person has dementia, but it may be difficult identifying the exact cause. With that said, though, health professionals are only able to diagnose with 90% accuracy. A brain autopsy must be completed in order to be 100% accurate at this time, unfortunately. Before a healthcare professional diagnoses a person with dementia, they will complete a multitude of tests. The first being a complete medical history, including a psychiatric history, history of cognitive behavioral changes, current and past illnesses, your current medications that are prescribed and over the counter, and your family medical history. And they ask for that family history to see if there's anyone in your family that has had dementia, which could increase your likelihood of developing it as well. Another step of the process is a physical exam and diagnostic testing, which includes taking your blood pressure, your temperature, your pulse, listening to your heart and lungs, collecting blood and or urine samples for laboratory testing, and other procedures to assess overall health as determined by the health professional. You may also have a neurological exam. The physician will closely evaluate the person for problems that may signal brain disorders other than Alzheimer's. The doctor will look for signs of small or large strokes, Parkinson's disease, brain tumors, fluid accumulation in the brain, and other illnesses that may impair memory or thinking. The physician will also test your reflexes, your coordination, muscle tone and strength, eye movement, speech, and your sensation. Mental status tests are an instrument used to evaluate a person's memory, ability to solve problems, and other thinking skills. These tests give an overall sense of whether a person is aware of symptoms, knows the date, time, and current location, If the person can remember a short list of words, follow instructions, and do simple calculations. A mood assessment will also be completed during the mental status. Two of the most commonly used mental status tools utilized are the mini mental state exam and the mini cog test. There are also genetic tests available that test the APOE risk gene and rare genes that directly cause Alzheimer's disease, again, the deterministic genes. However, health professionals do not currently recommend routine testing for Alzheimer's disease as there are no current treatments to prevent, slow, or cure the disease. So the results of genetic testing have no practical impact on medical treatment diagnosis. Testing for the risk gene is sometimes included as a part of research studies as well. The final professional test to be completed is brain imaging. Medical professionals will request an MRI, and or a CT. These tests are primarily used to rule out other conditions that may cause symptoms similar to Alzheimer's but require different treatment. Structural imaging can reveal tumors, evidence of stroke, damage from severe head trauma, or a buildup of fluid in the brain. The Alzheimer's Association reports there are numerous at-home dementia screening tests. However, none of them have been scientifically proven to be accurate, so they do not recommend this type of assessment. They highly recommend that a professional, so the medical field, complete all of the testing to determine if a person has a type of dementia or if it could be something else. They also say that the at-home tests are unreliable because the individual does not use the tool accurately, and they may get false positives. So treatment options for dementia. Although current medications cannot cure Alzheimer's or stop it from progressing, they may help lessen symptoms such as memory loss and confusion for a limited time. I had a neurologist tell me once before when I was working in the field that medications work 50% of the time for 50% of the population. I was surprised to hear that statistics from him, but then it started to make sense because it depends on what stage of dementia that the individual is living with and when medications are prescribed and when they are taken. So medications are likely to slow the progression of dementia at the early to mid stage versus mid stage to severe stage. So there are currently two types of medications currently approved by the FDA for memory, and that is, where did I put that? So those are Aricept, Exelon, Radazine, and Namenda. All of those can help with a person's memory and thinking. Then we have non-pharmacological treatment options on there as well. So those include social activities, adequate sleep, having a routine, proper stimulation, hydration, and occupational therapy. All of that is related to keeping the person's mind and body physically active. So even when you are diagnosed with dementia or you have someone you know diagnosed with dementia, keeping them active is very important for the overall health and brain. All right, so you may be asking yourself, why do I need to know all of this about dementia? There are more than 50 million individuals living with dementia worldwide, with 5 million living in the United States. Alzheimer's disease is the 6th leading cause of death in the US, with 1 in 3 seniors dying from a type of dementia. Dementia is the only leading cause of death in the top 10 that the United States cannot prevent, cure, or slow. Furthermore, according to the Alzheimer's Association International 2019 report, 62% of healthcare practitioners still believe that dementia is a normal part of aging, and 40% think the public healthcare professionals ignore people living with dementia. So we'll start with the world prevalence. So again, with the Alzheimer's Disease International 2019 World Report, there are over 50 million individuals living with dementia globally. a figure which is set to increase to 152 million by 2050. Currently, every 3 seconds, a person develops dementia. The current annual cost of dementia is estimated to be $1 trillion and is a figure to set to double by the year 2030. So in the United States, as I said, about 5.8 million Americans are living with Alzheimer's disease. This includes an estimated 5.6 million age 65 and older, and approximately 200,000 under the age of 65. 1 in 10 people age 65 and older has Alzheimer's disease. Almost 2/3 are women, which is 3.6 million, and 2.2 million are men. Older African Americans are about twice as likely to have Alzheimer's disease or another type of dementia as older whites. Hispanics are about 1.5 times as likely to develop Alzheimer's disease or another dementia as older whites. And by 2050, it is projected that 13.8 million Americans will be affected with a type of dementia. One reason for this is due to the rapid growing aging population. And as I said, Alzheimer's is the 6th leading cause of death in the United States. It kills more than breast cancer and prostate cancer combined. The only cause of death in the top 10 that cannot be prevented, cured, or slowed. Every 65 seconds, someone in the United States develops Alzheimer's disease, and 1 in 3 seniors die with a type of dementia. As for our caregivers, we have 16 million caregivers that aided older adults living with dementia. That is estimated to be about 18.6 billion hours of care, which is valued at $244 billion. In 2020, a total national cost of caring for people with dementia is projected to reach $305 billion, which does not include the $244 billion in unpaid caregiving. Medicare and Medicaid are expected to cover $206 billion, and $66 billion will be out-of-pocket spending. So in South Carolina, according to Alzheimer's Association, there are 95,000 individuals that have been diagnosed with dementia in South Carolina. This number is projected to reach 120,000 by 2025. Persons with dementia reside in hospitals and hospice, but also in the community. But hospitals, a person with dementia, there has been 21.3% increase in ER visits since 2007, and 21% of people with dementia are readmitted to a hospital. And about 20% of people in hospice have a primary diagnosis of dementia. In South Carolina, the cost of care of persons with dementia is almost $24,000 from Medicare and $652 million from Medicaid. They projected increase of 25% from 2020 to 2025. One common question I always get is, why is Medicare only providing $24,000? We have to remember what Medicare does and does not cover. For many people 65 and older, their primary insurance is Medicare, and they have a backup of Medicaid. Unfortunately, Medicare doesn't cover a lot of additional health-related issues. So that's where Medicaid kicks in for a majority of that cost. So in South Carolina, we have roughly 318,000 caregivers, which provide roughly 362 million hours of care, and that is valued at $4.7 billion. One last important statistics to note for South Carolina is that there have been 2,616 deaths from Alzheimer's disease. This is a 199% increase since 2000. Alzheimer's disease is the 5th highest death rate in America in South Carolina, and is the 6th leading cause of death in South Carolina. So a little bit more in South Carolina. These statistics are from the 2019 annual report from the South Carolina Alzheimer's Disease Registry, which is housed in the Office for the Study of Aging. There's only 3 registries in the nation, and South Carolina's is the oldest by far. It was developed and put into law in 1988, if I recall accurately. So we are able to get the statistics that were provided from the Alzheimer's Association, but also statistics from our database and analyze what's happening in our state. And of course, question what's going on in this county versus this county, and noticing those differences and try to implement services to help decrease the growing development of dementia. So according to our registry, in South Carolina, there are nearly 96,000 individuals living with dementia. The types of dementia in South Carolina include 63% Alzheimer's disease, 11% vascular dementia, 3% mixed dementia, and 23% are other conditions, which include dementia diagnoses related to other medical conditions. In terms of race, 63% are white or Caucasian, 28% are African American, and less than 1% are Hispanic, and 9% are all other races. It is important to note the racial difference in South Carolina compared to the United States. Older African Americans in South Carolina are 64% more likely to have dementia when compared to older non-Hispanic whites. This is an overrepresentation when compared to the national average of two times more likely, whereas the Hispanics are underrepresented when compared to the national average of 1.5 times more likely having the disease compared to older non-Hispanic whites. The last statistic to mention is on gender. In South Carolina, 63% of individuals living with dementia are female and 37% are male. All right, so now we are going to move into quickly highlight some stages and what to expect with Alzheimer's disease. So in early stages of Alzheimer's, a person may function independently. He or she may still drive, work, and be part of social activities. Despite this, the person may feel as if he or she is having memory lapses, such as forgetting familiar words or the location of everyday objects. Symptoms may not be widely apparent at this stage, but family and close friends may notice, and a doctor would be able to identify symptoms using diagnostic tools. So some of these include coming up with the right word or name, remembering names, not remembering names when introduced to new people, and having difficulty performing tasks in social or work settings, forgetting material that was just read, losing or misplacing valuable objects, experiencing increased trouble with planning and organization. Individuals with early stage Alzheimer's disease are very good at hiding the fact they are having memory lapses. So they may just give you excuses, say, oh, I'm tired today, or, oh yeah, I just remembered, but I just couldn't get to it today, or something like that. So if you do not interact with the person on a regular basis, you may not realize something is wrong. But if you do interact with that person regularly, you will notice those changes. So middle stage Alzheimer's is typically the longest stage and can last for many, many years. As the disease progresses, the person with Alzheimer's will require a greater level of care. During the middle stage of Alzheimer's, dementia symptoms are more pronounced. The person may confuse words, get frustrated or angry, and act in unexpected ways, such as refusing to bathe. Damage to nerve cells in the brain can also make it difficult for the person to express thoughts and perform routine tasks without assistance. Symptoms which may vary person to person include being forgetful of events or other personal history, feeling moody or withdrawn, especially in social or mentally challenging situations, being unable to recall information about themselves, like their address or telephone number, and the high school or college they attended, experiencing confusion about where they are and what day it is, requiring help choosing proper clothing for the season or occasion, and having trouble controlling their bladder and bowels. They may also experience changes in sleep patterns, such as sleeping during the day and becoming restless at night, showing an increased tendency to wander and become lost, and demonstrating personality and behavioral changes, including suspiciousness and delusions and compulsive repetitive behaviors like hand wringing or tissue shredding. In the middle stage, a person with Alzheimer's can still participate in daily activities with assistance. It's important to find out what the person can still do and find ways to simplify tasks. As the need for more intensive care increases, caregivers may want to consider respite care or an adult daycare center so they can have a temporary break from caregiving while the person living with Alzheimer's continues to receive care in a safe environment. All right. In the final stage of disease, the dementia symptoms are severe. Individuals lose the ability to respond to their environment, to carry on a conversation, and eventually to control movement. They may still use words or phrases, but communicating pain becomes difficult. As memory and cognitive skills continue to worsen, significant personality changes may take place and individuals need extensive care. At this stage, individuals may require around-the-clock assistance with daily personal care, lose awareness of recent experiences as well as their surroundings, experiences changes in physical abilities, including walking, sitting, and eventually swallowing, have difficulty communicating, become vulnerable to infections, especially pneumonia. The person living with Alzheimer's may not be able to initiate engagement as during the last stage, but he or she can still benefit from interaction in ways that are appropriate, like listening to relaxing music or receiving researchers through gentle touch. During this stage, caregivers may want to use supportive services such as hospice care, which focus on providing comfort and dignity at end of life. Hospice can be a great benefit to people in final stages of Alzheimer's and other dementias and for their families. Okay, almost done, but I just want to give some information from a caregiver's perspective. So as a caregiver for a person with dementia, you may not realize how much the disease is changing them. You may feel that the person you're caring for can control things when they really cannot. You may think the person with dementia is acting lazy or stubborn for refusing to dress and bathe, and sometimes you may believe that the person with dementia says or does things on purpose to frustrate or to hurt you. These feelings are common among caregivers, and that is okay. However, in learning more about dementia, you'll realize that you should direct your frustration and resentment towards the disease, not the person living with dementia. Understanding dementia will help you direct your compassion, understanding, and quality of care towards the person you are caring for. So caregiver self-awareness. Caregivers can affect the caregiving can affect the caregiver's life in many ways, including their ability to work, engage in social interactions and relationships, and maintain a good physical and mental health. Caregiving can also bring great satisfaction and strengthen relationships, thus enhancing the caregiver's quality of life. With that said, though, we know caregiving is exhausting mentally, physically, and spiritually. There are burdens and stress to care for a person with dementia is often higher than other illnesses, and depression is also more common. In order to combat the negative effects of caregiving, a caregiver must engage regularly in self-care. Self-care is not selfish, and it is not wasting your time. It is essential for you as a caregiver for your overall health and well-being, and thus the quality of care you provide. So 10 symptoms of caregiver stress, so you are aware, is denial about the disease and its effect on the person who has been diagnosed, anger at the person with Alzheimer's or frustration that he or she can't do things they used to be able to, social withdrawal from friends and activities that used to make you feel good, anxiety about the future and facing another day, depression that breaks your spirit and affects your ability to cope, exhaustion that makes it nearly impossible to complete necessary daily tasks, sleeplessness caused by never-ending list of concerns, irritability that leads to moodiness and triggers negative responses and actions, a lack of concentration that makes it difficult to perform familiar tasks, and health problems that begin to take a mental and physical toll. So just a quick tip for managing these stresses: identify your community resources. So you can find resources for you as a caregiver, but also for the person you're caring for. Get help and find support, whether it be formal and informal supports. So it can be a support group, it can be your medical professionals, it can be a church that you're a part of. Use some relaxation techniques. Get moving. So even if it's just 10 minutes of walking a day, that will help you. Find time for yourself. Do something that you enjoy, not that something you have to do. Become an educated caregiver. So as the disease progresses, new caregiving skills may be necessary. Utilize resources to identify and prepare yourself. Again, take care of yourself. Visit your doctor regularly. Eat well, sleep, and don't push off your appointments. If you have an appointment, still take that appointment. And make legal and financial plans. So putting legal and financial plans in place after an Alzheimer's diagnosis is important so that the person with the disease can participate. Having future plans in place can provide comfort for the entire family. Many documents can be prepared without the help of an attorney. However, if you're unsure about how to complete the legal documents or make financial plans, you may want to seek assistance from an attorney specializing in elder law, a financial advisor who is similar with an elder or long-term care planning, or both. All right, so I just wanted to share the Alzheimer's Association's information. So alz.org is their website, and they do have a 24/7 helpline, and the number is on the screen. And literally, they're there 24/7. Even if you think it's a silly question, they're there to help you, and they can provide references and sources for you in your own community as well. So my contact information here for you. If you want to learn more about dementia, we do have a program called Dementia Dialogue. It is 5 modules, and we are working on putting it online. So hopefully soon you can access that online, do an asynchronous learning or do synchronous learning with an instructor. And we have over 120 instructors in 4 different states, and we are adding more regularly. My references, and you know about me. Okay.
Well, thank you, Megan, for that jam-packed presentation. As you mentioned that it would be, you promised that it would be at the beginning. So thank you for all of the information that you shared with us about dementia and Alzheimer's disease. We didn't see any questions, or I didn't see any questions in the chat, but I have one that may get us started. So you kind of jokingly, when you were sharing the slide about signs and symptoms, I believe, of dementia, kind of jokingly said, well, if these were signs, you know, certainly I might have some, or I might have this, but I wonder if there has been some discussions about how COVID may be impacting folks in terms of just regular, what you kind of identified as memory loss or kind of signs of age. I would imagine that some things are a lot more magnified now, as many of us are kind of thrown out of what normalcy used to feel like. And so any thoughts about if there's been some discussions on the national or international scene about that?
I haven't stumbled across any research specifically yet. However, I do know the Alzheimer's Association has a separate tab specifically for living with dementia and COVID-19. But yes, you are right. Everyone's routine has been thrown off. There are days when I've asked my Alexa, what day is it? Because I had absolutely no idea what day it was. But to learn, okay, so if you get back into a routine, you know, okay, well, it's Friday, tomorrow's Saturday, I have X, Y, and Z I know I need to do. So it's once you get back into a routine and you know, okay, not a problem. But even if you get back into a routine and you're not able to remember things, or there are things in your daily life that are disrupted, that you can't remember how to get to work, or how to check your mail, or even how to pay a bill, those are red flags. So sometimes it can seem like a fine line, but when you think about it, or if you have someone else help you think about it, they mention things, you may realize, oh, okay, this is severely impacting my daily life. I should probably go to my doctor to figure out if it is dementia or if it is something else that can be treated.
Okay, great, thank you.
Hi, this is Marvella. I just had a question as a follow-up to that. So with COVID-19, a lot of people I think, may not be going to their regular medical appointments. And so, what do you think might be the impact on dementia care for people if they're not seeing their cardiologist or their endocrinologist to manage their diabetes, and they have dementia, and they may not be getting the proper dementia care as well?
Yes, so thankfully, our medical providers are having virtual visits now, but I also realize with our current aging population, virtual visits are near impossible. So if you can have someone that can help them set up their virtual appointment and be there with them, I think that'll be the best for the individual to ensure they're getting that care. Otherwise, yeah, it's not a great time right now for anyone, but especially for people living with a type of dementia. Unfortunately, I don't have a direct answer for you at this time.
Yeah, no, thank you. I mean, I know that even for things like cancer screening, there's, I'm told that we're going to see increases in not only in cancer cases that are further developed than they would have been if people had been getting screening when they were supposed to be getting it.
Right.
Because
and
people
I can,
yeah.
just as a personal thought here, that I can see because we're spending more time with our loved ones, sometimes more than we really want to, I can see that we can say, okay, yes, there are issues here that I cannot no longer deny or say that's not happening because it is in my face every day. So hopefully that person, the caregiver, say, okay, we need to schedule an appointment to talk to our doctor or a counselor or some sort of medical professional to see if there are memory impairments again, or if it can be something else. Especially our older folks, if they have a urinary tract infection that can mimic memory impairment and signs of dementia. So the doctors are more likely going to do all of those medical workups to make sure it is not something that can be treated before saying that, yes, it's dementia.
You know, that's a really good point, that with Skype, I mean, if people are able to Skype their older relatives, you're right. They may spend more time like directly looking at them, interfacing with them, and picking up on those little signs. That would be really interesting to study.
It would be, for sure.
Thank you for that discussion. We do have a question in the chat. Any advice on how to deal with denial from family members?
Denial is a huge issue with dementia, specifically caregivers. Then most people are diagnosed with when they're in the moderate or middle stage of Alzheimer's disease, because there's so much denial with the individual in the family that they don't go get an early diagnosis, which could be hard for the individual, because you can go into clinical trials that they're having with any type of dementia, and you can get a clinical trial treatment, which may or may not work, but can be a part of that and hopefully help others as well as yourself. But I would suggest, if you are uncomfortable having the conversation, or you know someone else in your family, including that person living with dementia, they may not want to hear it from you. So having a third party, such as a medical professional or even a counselor, can help overcome those barriers. And I know a lot of medical professionals don't want to initiate that conversation because they don't want to be portrayed as the bad guy. But if you talk to the doctor ahead of time, or even the nurse, and say, hey, we're scheduling this appointment so you can talk and give information, so we aren't the bad person, because we are taking care of this person every day or every other day, however often you're taking care of it, and you don't want to have a negative impact on your relationship, that's one way to do that.
Thank you, Megan. Daniela, if you want to follow up, I see your question here. What are people's thoughts about next steps regarding diagnosis tools and research needed in ADRD? Was that your question?
I think she's asking everyone in the group what their thoughts are.
Okay. Anyone want
Sorry,
to-
I was on mute. I apologize. Well, I throw it out to Megan, but just in general, I know there's, been discussions and systematic reviews about, when diagnosis should take place, and there was the movement that we should diagnose earlier. But it, just thinking about the latest with, the documentary that's coming out with the actor, I thought of Robin Williams and how, they thought he had one disease, and then after he died, they're now talking about Lewy body dementia. So just wanted to, get your thoughts, Megan, or just in general, where people think that the work needs to go with respect to diagnosis and timing and the tools that are used, etc.
I know just a little bit. Personally, I went to the Alzheimer's Association's annual conference, I guess a year ago now, and the scientists are making progress with diagnosing individuals more accurately rather than just a brain autopsy after the individual passes away. So I know they're looking at diagnosing through blood tests. I think there was something about eye scans as well. That way, again, you don't have to have that brain autopsy. It's not just a screening, and you can get a definite yes or no, but it may not indicate what type of dementia you have. But I do think we need more research and more answers, but because dementia is so different person to person, I often refer to as schizophrenia, where schizophrenia, yes, in your DSM-5, there is the criteria, but it shows up so differently person to person, it's very difficult to diagnose, and that's how I feel about dementia. That say, yes, I can say you have dementia based on the criteria, but I'm not sure which one it is at this time. I've had a client who was diagnosed in his early 50s because his mother and father also had a type of dementia. And we could not figure out what type of dementia he had because he went downhill really quickly. Then he had head trauma. It was just a disaster. But when he passed away and the doctor and I sat down and talked about it over more and more, he was like, I think he had Lewy body dementia or even Parkinson's disease, but we could not find that out through the testing because we just did not know.
Thank you.
Yes, thanks for that, Megan. Any final questions for Megan? Feel free to unmute at this point if you have a question. As folks may be thinking, please join me in thanking Megan for her presentation for us today. Thanks so much, Megan. All right, we do have a comment. This is from a pediatrician regarding her grandmother. We're not going to see a doctor since you can't do anything about it. Her medical hat isn't on and denial hat is. She stated the great-grandmother's dementia was really bad, and so even though her grandmother is middle-aged, it's just not as bad. And Rebecca, if you want to follow up on that by unmuting yourself.
My mouth just dropped open when I heard that. But I would say, unfortunately, get another doctor. We don't have, I think I saw on the slide there were like 66 geriatricians in South Carolina, which is not a lot, especially when you think about we have nearly 96,000 individuals living with a type of dementia. But if your medical provider is not willing to talk to you about dementia or says, oh, it's not that bad, I would definitely get another physician that would be working to work with you and to provide resources.
Thank you, Megan, and I'm sure you may be able to even provide some of those specific resources through your role with the Center for the Study of Aging.
Yes, so anyone has any questions anytime, feel free to contact me.
Great, thank you. So you're getting plenty of accolades in the chat, so I'll let you take a look at those while I wrap up for us. So thank you all for joining us today, and thank you, Megan, again for your presentation. A couple of announcements for the good of this group. First, I am honored to announce and present to you the newest cohort of scientists for our CADMR Center. You see them pictured here, and I know that they are all present and accounted for, so thank you all for being here. Our three 2020-2021 pilot project awardees are Dr. Monique Brown. She's an assistant professor of epidemiology and biostatistics and faculty affiliate in the Smart State Center for Healthcare Quality at the University of South Carolina. Her project is entitled Health Disparities in HIV, Depression, and Alzheimer's Disease in South Carolina. Next, we have Dr. Kaylee Byrne. Kaylee is an assistant professor of cognitive psychology at Clemson University. Her project is entitled Identifying Racial Disparities of Dementia, the Role of Social Isolation and Social Technology Use, and how timely is that? And lastly, we have Dr. Stephanie Urania, postdoctoral fellow in the Department of Health Promotion, Education, and Behavior, also at USC. Her project is entitled The Impacts of Military Service on Cognitive Function and Racial Disparities. So I'll ask you to please join me in welcoming them to our center. So sort of like the mob, once you're in, you can't get out, or some kind of quote like that. So this is the beginning of their year of pilot funding, but certainly once you're in our center, we hope that you will continue to stay connected. And I think I at least noticed one of our previous scientists, Miriam, here as well. So and Karina, I believe, and Kevin. And so once you're in, we do invite you to continue to participate in our seminars and any of the other resources that we have through the center. Our second announcement is, in order for us to continue offering health disparities and minority aging content that is of interest to you, we ask that you complete a brief survey to let us know how we're doing and to give us your ideas for future seminars. You may use the QR code here on the slide to access the survey, or we can email you the survey using the email address that you provided us. And then lastly, our final public seminar of the year will be in November, with that date to be announced closer to November. The topic will be introducing the regional Alzheimer's disease registries. So please be on the lookout for communication from Quentin McCullum about further details. And if you would like more information about upcoming seminars or other activities sponsored by the CADMR, please visit our website. Okay. You can also email our points of contact, Quentin McCullum and Brianna Ashford. Thank you guys. So CADMR leadership or CADMR team, any closing messages, comments?
Wonderful seminar, Megan, to kick off our year of